infected and not infected people, thus can reduce the chance of disease transmission. For example, the number of new cases in the United Kingdom significantly reduced since the announcement of the lockdown measure in this March. But keep people from consumption and working will cause the recession and damage the economy. So how can policymakers optimally make policies under these circumstances? So the goal of this project is to find the optimal lockdown policy as policymakers. There are some literature about the optimal policies in epidemic under the framework of SIR model and its variants. The policies including fiscal policy, testing and quarantine, the intervention policy among multi-aged groups, and social distancing, and the lockdown control like we do. So what we innovate from the previous works are that they only took the government's perspective, but did not take people's own reaction to the pandemic into and the government's policy into consideration. While we extend the SIR model by involving people's economical decision making, the consumption and the working hours, and embedded the SIR model in a simple general equilibrium framework to model people's reaction to the government's containment policy. Furthermore, we emphasize the cost of death in our model objective of the policymakers, which is an important factor in real-world government decision-making. By doing this, we also enable the lockdown policy to find a balance between the impact of the epidemics and the economy. Next, I will introduce you the classic SIR model and our extension to it to model the transition of the epidemic. The SIR model defines the dynamic of disease transmission among the population. The SIR refers to susceptible, infectious, and recovered people. As you can see from the left-hand side picture, the susceptible people could become infected through the contact with infected people. In infection transmission rate alpha, infected people can either recover with recovery rate beta or become dead with death rate mu. This model assumes there's no second-time infection once the people recovered. The dynamic of SIR model is formally defined on the right-hand side, where the SIRD are the number of susceptible, infectious, recovered, and dead people. The N is the number of the whole population. The CFR and R0 are two important indicators of the severity and the transmission speed of the epidemic. The case fatality rate, or CFR, refers to the population of deaths from the certain disease compared to the total number of people diagnosed with the disease for a particular period. A higher case fatality rate means the higher chance of death if one gets the disease. The basic reproduction number, or R0, refers to the expected number of cases directly generated by one case in a population where all individuals are susceptible to infection. If R0 keeps below 1, the disease is likely to slow down the speed of the transmission. If the R0 is above 1, the disease is likely to increase its speed of transmission. The basic reproduction number is a basis of intervention policies making of some governments. There is an assumption in the SIR model as well as our extension to the SIR model, that the case fatality rate is a constant because the change of the number of recovered and death people are both a constant ratio of the number of infected people. I'm going to look at the real-world data to see if this assumption makes sense. The data source we use is the HPCC system COVID-19 cluster. The cluster contains various sources of data related to the COVID-19. For example, the specific data we use is the public metrics data. The file names is on the left-hand side picture. The levels here means the level of region. For example, the level 0 is the overall world data. The level 1 specific in countries, and level 2 and 3 is further down to smaller regions. We use the level 1 data as you see from the right-hand side picture. The country we look at is the United Kingdom. Each period here means a week from the start date to the end date. So this is the specific data of the United Kingdom. The screenshot here is not so clear. I'll explain it to you. The columns include the number of accumulated cases, the deaths, the active cases, the daily case fatality rate, the social distance indicator, medical indicator, and many other metrics. We mainly use the case fatality rate here. This picture shows the case fatality rate of the United Kingdom from April. Each point refers to the average case fatality rate of the past 7 days. The points in the middle here has the high case fatality rate because some of the cases before were not counted in previous statistics and they were added to the numbers here. So we do not look at this abnormal numbers. So we can see apart from the abnormal points, the case fatality rate of the United Kingdom does not vary much in this like over 2 months period. So the constant case fatality rate is a reasonable assumption. So we extend the SIR model to involve people's decision of working hours and consumption, similar as the classic SIR model. We assume all population belongs to either susceptible, infected, or recovered people. Suspected people can be infected. Infected people can become recover with probability pi r, or become dead with probability pi d. We extend the SIR model by specifying the way that suspect people become infected through the contact with the infected people. There are 3 ways that the suspectable people can be infected: by purchasing or consumption goods, working, or by other approaches. The pi s1 here reflects both the amount of time spending on consumption and the probability of becoming infected as a result of consumption. And we can similarly define pi s2 and the pi s3. The CT and NT here denotes the consumption and the working hours of people. The TT here is the newly infected people. So as you can see, the left-hand side is the dynamic of suspectable, infected, and recovered people. So under the extension of SIR model, the lockdown control is the regulator on people's working hours, which sets an upper bound for people's working hour as N0 times LT. The N0 here is the number of working hours of people in a time period, for example, a week, if there is no pandemic. In our model, we assume that the lockdown control rate LT is the same for all three kinds of people, which is to say the LTS, LTI, and LTR here are the same. So in the smart containment setting, which I will introduce later in the experiment, we will see what if the lockdown control rate L can be different for the three kinds of people. Next, we define the decision-making problem of the three kinds of people, susceptible, infected, and recovered, as well as the decision-making of the policymaker. We assume the utility of every individual is this formula is equal to log CT minus theta divided by 2 times NT squared, where CT and NT are the consumption and working hours of the individual in a time period. This is an increasing function to CT and is decreasing to NT. The parameter theta here satisfies that the theta times N0 square equals to 1. This is to make sure that the utility reaches the maximum when the NT is equal to N0. So every individual maximizes their accumulated utility from time step 0 to infinity, or in our model, it is the finite time horizon t, by making decisions on their consumption and working hours. The decision-making of recovered people is defined here. The objective is the accumulated utility. The beta is the discounted factor. Meanwhile, the consumption CT has to be less than their productivity. The parameter A here is the productivity rate. Their working hours NT has to below the upper bound constrained by the lockdown regulator LT. As I mentioned before, N0 is the number of working hours people of people in a time period if there's no pandemic. And then we formulate the decision-making problem of infected and susceptible people. There are some difference between their decision-making problem with that of the recovered people. First of all, the formulation of accumulated utility is different because infected people have the possibility to become recovered or dead, and the susceptible people have the possibility to become infected, while the recovered people keeps as recovered all the time, as we assume there's no second time infection. Secondly, the parameter phi here in the constraint on the consumption in the decision-making problem of infected people is a discounted factor on the productivity of the infected people. It is reasonable as getting the disease will certainly reduce people's working productivity. For the behavior of the three kinds of people, we proved that the recovered and infected people will work and consume as much as possible. The susceptible people will also consume as much as possible, but they may not work at the maximum because they have chance of being infected, which will reduce their utility. So after defining the decision-making problems of all three kinds of people, we formulate the problem of decision of the policymaker. The policymaker maximize the summation of accumulated utility of all people by controlling the lockdown rates LT under the equilibrium of the three kinds of people. The equilibrium is the solution of the decision problems of the three kinds of people that we introduced before. And the CT stars and NT star here are the solution of the previous problems. Next, we emphasize the cost of death in the model objective of the policymaker. We do this because the death caused by the epidemic has negative influence on the society. For example, it could arise panic among people and cause damage to the family members. And specifically, we penalize the number of deaths on the model objective with the utility of recovered people. The penalty parameter lambda here can be viewed as the severity of the death in the policymaker's view. By adding the penalty on death in the objective, we could also it could also enable the result lockdown policy to seek the balance between the economical and health cost during the epidemic. So how do we solve the previous problems we defined? There are two phases of the problem. One is the calculation of equilibrium to get the optimal consumption and working hours of the three kinds of people. The other is the optimization of lockdown control rate, LT. We calculate the equilibrium by solving its first order conditions using the MATLAB function LSQ long linear. This is a function to solve nonlinear data fitting problems that include upper and lower bound constraints. For the optimization problems of LT, we apply MATLAB function fmincon that solves the optimization problems with upper and lower bound constraints with gradient methods. So this is the end of the model introduction part. Next, I will talk about the parameter estimation. Apart from the parameters in the classical SIR model, in our model, we need to specify additional parameters. A, the productivity rate, the N0, the working hours if there is no pandemic, and pi is 1, pi is 2, and pi is 3. And the probability of being infected by the three ways of contact between susceptible people and infected people. Among these parameters, the A and N0 can be directly estimated by historical income and working hour data. For pi is 1, pi is 2, and pi is 3, we in the SIR dynamic model, we have this equation here. And on the right hand side, in the first two equations, the T1 is a time point before the lockdown, and T2 is a time point after the lockdown. You can see the difference here is the first equation. The second equation has the lockdown regulator LT, so that would result in different parameter of transmission. And the third equation, we assume the time of the three approaches of being infected. So there's a ratio between the pi is 3 and the pi is 2. So combining these three equations, we can get the pi is 1, pi is 2, and pi is 3 estimation. For parameter settings in the numerical experiments, we take the UK, for example. The LT can be roughly estimated by the government data reports. The UK started the lockdown on March. The government released the experimental results of the Office for National Statistics online. They use they report the working hours, people the hours they work from home and the time they spend on other activities. We estimated the LT to approximately around 0.65. And according to the same data source, the average actual working hours of the full-time workers in the previous years can also be found. So we can get the estimation of N0, which is 36.9 of hours in 1 week. For the pi is 1, pi is 2, and pi is 3, we use the estimation of the reproduction number R0 before the lockdown and after the lockdown to calculate the pi T1 and pi T2 here. And so that we can get the estimation of pi is 1, pi is 2, and pi is 3. For the parameter A, we use the average annual earning data to and then divide the working hours to get the productivity rate A. And there are some other parameters. For example, the discount factor in the infected people, and we use the parameters from previous literatures. So next, I'm going to show you the results of our experiments under the parameter settings I just mentioned. We are going to firstly compare the optimal control versus no control, and the early ending and the late start of the lockdown policy. We're also going to analyze the impact of the cause of death, and we're also going to introduce the smart containment and analyze the reproduction number. In our experiment setting, our initial state is the three numbers here are the number of the proportion of susceptible people, infected people, and recovered people, respectively. And the time horizon we experiment is 100 weeks. So this is the result of the optimal control. The black dashed line is the case if there is no control, and the blue line is the optimal control. As we can see from the picture, if there's no lockdown control, or to say the lockdown rate is the constant 1 for the all time, then under our parameter setting, around 15% of the population will be infected, and 0.3% of population will die, and the peak of infection will be above 0.6% at around week 50. The optimal lockdown rate starts from 80%, then gradually released to above 59%. The speed of increasing of the lockdown rate first decreased until around week 50, then increased until week 100. The proportion of infected people decreased at week 50, then rise at week 100. 0.37% of population will become infected, and 0.6 and much less population will die by week 100 compared to the no control case. The increase of the infected population is because that our model has finite time horizon and do not take the consequences after the time horizon 100 week into consideration. The optimal lockdown policy reduced the peak of an infection and reduce the amount of deaths in a large percentage. The significant life saving is associated with recession. The aggregated consumption under the optimal lockdown policy decreased 20% compared to no control case at the beginning, but then constantly increases. The average aggregated consumption fall by 6% with the optimal lockdown measure. The reason that the optimal lockdown control policy did not cause severe recession might be that in the no control case, the susceptible people will cut back their working hours as well as their consumptions as the infected population increases. And in the optimal lockdown control, restricted the infected population, so the susceptible people will not cut back their consumption as much. We proved that the recovered and infected people will work as much time as possible in order to maximize their own utility, but the behavior of susceptible people is not certain. In the parameter setting of our experiments, the susceptible people almost work as much as possible, just as the infected and recovered people do, but slightly reduce their working hours from the upper bounds of the lockdown constraint near the end of the horizon. This behavior may be due to the increase of the infected population, which raises the risk of getting infected for the susceptible people. And practically, the decision makers may, under the pressure that of economical laws, that force them to end the containment policy in the middle of the pandemic. So here we discuss the consequences of doing this. So as we see in the previous result, that the infected population reaches the bottom at week 50, so which may seem to be a good time slot to end the lockdown policy. So our results here shows there is an instant bounce of the consumption right after the end of the lockdown control, but this would cause an instant rise of the infected population, which would result in a recession. So ending the lockdown policy prematurely may not bring long-term economic benefits, and what's worse is that it would result in substantial additional number of deaths. So therefore, we suggest that the policymakers to avoid terminating the lockdown policy during the pandemic in pursuit of only a short-term economical benefit. So policymakers could also face the situation that there are things prevent them from taking the lockdown measure at the early stage of the pandemic. So our results in this figure shows the optimal lockdown control policy that starts at week 13. It's around 3 months later, compared to the optimal lockdown policy, which is the blue dashed line here. The optimal lockdown policy started at lockdown rates 80%, while the late started lockdown policy starts with a stricter constraint rate of 73%. Although the lockdown rate of the late started policy constantly increases, it is always less than the original optimal lockdown policy. The late started causes a slightly stronger recession. The average aggregated consumption reduced about 1%, and it also caused a substantial rise of deaths. The number of deaths rises about 80% by week 100. It is the earlier the better to start the lockdown policy. Despite that the late start of the lockdown policy brings additional loss, it is much better than applying no lockdown policy or abandon it too early. Next, we discuss the severity of death regarded by the policymakers and how this affects the optimal control policy. We set the penalty coefficient of death, the lambda, as 0, 10, 20, and 50, which means one death of people is regarded as the loss of 0, 10, 20, 50 recovered people by the planner. When the lambda is equal to 0, it's the same as the original optimal control. Our results in this figure shows adding the policy on the deaths, it makes a huge difference. It significantly slow down the increase of the lockdown rate, thus reduce the proportion of deaths and infections in a great extent, and avoids substantial rise of the infection population. So these are the beneficial in terms of mental impact in the society, as low death and low infection amount release the pressure on both people in the society and the planner. As the penalty coefficient increase, the optimal control policy becomes slightly strict, and there is a slight recession when adding the penalty number on the death. The relation of death penalty coefficient and the result optimal control rate is below linear. Despite the optimal lockdown policy with different death penalty coefficient starts quite different lockdown rate, they quickly becomes close, and at the end of the control, the aggregate consumption as well as the lockdown rate of the optimal policy is extremely close to the one without death penalty. And in the previous lockdown control policies we started, the government chooses the same lockdown rate for all three kinds of people. So here we consider the smart containment, by which means the policymakers directly chooses the working hour and the consumption for all three kinds of people. And there's no need to apply any lockdown on the recovered people because their utility reaches the maximum as their working as their working hour is at the maximum, and they do not affect the utility or transition of the susceptible people and infected people. So here's our results on the smart containment. Our results show that the infected people almost do not work at the beginning, but the planner gradually increased their working hour as the infected population decreases rapidly, and the susceptible people work almost without fear of being infected. This picture shows that compared to the previous optimal lockdown control policy, the smart lockdown control policy is much better since it reduced the number of deaths in a great extent and almost avoids the recession because the proportion of infected people is extremely small. The implement of the smart lockdown control policy requires the planners to know the status of all people and have control to their working hours. In reality, the knowledge of people's status needs measures such as medical testing and rely on the accuracy of testing. So our results suggest that these measures and information that is helpful for taking smart lockdown policy are beneficial for the social welfare. So here's all the basic reproduction number in our previous lockdown policies. As we can see in this picture, the R0 of the smart lockdown control is much smaller than the rest of other lockdown policies, and the R0 of the lockdown policies with the same lockdown control rate for all three kinds of people behave similar to their lockdown rate, while in the no control case, its R0 decreased constantly, and the R0 of the smart lockdown control policy behaves similar to the lockdown rate of its infected people. This is because the behavior of all three kinds of people is in accordance with the lockdown rate in the optimal lockdown control policies, while the behavior of the susceptible people varies if there's no control. And in the smart lockdown control case, the susceptible people and recovered people almost remain the lockdown rates constant one in the whole control process. Thus, the R0 behaves in accordance with the lockdown rate of the infected people. Notice that although the R0 in the no control case decreases below 1, and the R0 of the lockdown control policies without death penalty increases over 1, the policies with lockdown control is much better than that without control, as we analyzed before. So we therefore suggest whether R0 is larger or less than 1 cannot be the only foundation for planners to make judgments or decisions on current situations. So to summarize, in this work, we extend the classic SIR model to study the interaction between the economical decisions and the epidemics. In our model, people in different health status take different decisions on their working hours and consumptions to maximize their overall welfare. And the policymakers control the lockdown rate to maximize the social overall welfare, which lead to a two phases optimization problem. And several parameters in our model are not easy to specify using common epidemic data. So we provide a way of parameter estimation through various additional sources of data. Our results suggest that, firstly, the lockdown measures could be effectively reduce the deaths and the infections caused by the epidemics. Secondly, there is an inevitable trade-off between the short-term recession and the health problem caused by the pandemic, and how policymakers deal with this could lead to very different decisions. We quantify the trade-off of the by emphasizing the cause of death in the model objective, and that enabled the optimal lockdown control to find the balance between the economical and epidemic outcomes. Thirdly, the timing of starting and ending the lockdown control policies make much difference in terms of both economical and epidemic outcome. It is the earlier the better to start the control, and it is crucial to avoid prematurely ending of the control. Fourthly, in the analysis of the smart containment policy, we suggest that the additional information about the health status of people is beneficial, as the optimal lockdown control policy will reach much better economical and epidemic outcome if it could be implemented in different health status of people separately. At last, through the comparison of the lockdown policies, we suggest that the R0 cannot be the only foundation for the policy making. So that's all for today. Thanks for listening. And here's my email address. In case if you have any questions, you can email me. Thank you.
Thank you so much, Yuting, for that really enlightening presentation on a topic that is on all our minds at the moment. I have got a few questions for you from the floor. So are you ready to take one or two questions before we close the session?
Okay, I'm looking at the questions.
Would you like me to read one of the questions out for you, Yuting, or will you?
Okay, there's a question asking, can you comment on any plans to make the research results available to wider audience? We are writing a paper on the results we've got so far, and it's nearly finished, and we will submit the paper shortly. And there's a question asked about the aspect of HPCC system of use. In this project, we use the COVID-19 cluster of the HPCC system. I think the data sources, the various data sources in it are really helpful for our model.
And there's one final question that just came in from the floor, which I think we just about have time to take.
The final question asks if the model is validated for the passing post-lockdown in previous months. I think this is an interesting one. We haven't checked this. I think maybe we will do it later.
Okay, well, thank you so much for those of you who posed questions for Yuting to answer. And thank you, Yuting, for presenting to us today. It's been a really great session, which gives us a lot to think about. So thank you so much for being here today.
Thank you, Lauren, and thanks, everyone.